Every year, an enormous number of people undergo surgery simply because a doctor told them it was needed. And a surprising share of those procedures turn out, in hindsight, to have been avoidable. This isn't about a handful of bad doctors making mistakes. It reflects a pattern built into how medicine is practiced. Operations get recommended because they're familiar, quick, and routine, not always because they're the only option. Take diagnostic laparoscopy. The name sounds technical, but the idea is simple. A surgeon makes small cuts in the abdomen, inserts a narrow camera, and looks around. Not to treat anything, just to figure out what's going on. To get that camera inside, a hollow instrument called a trocar is pushed through the abdominal wall near the navel. Because the abdominal cavity is packed with organs, doctors first pump in carbon dioxide gas to create room to see. This inflates the belly, raises internal pressure, pushes the diaphragm upward, and makes breathing shallow. If the pelvic organs need examining, the patient is tilted head down, a position the body never naturally experiences. That gas pressure stretches ligaments and tissues that were never designed for it. When the procedure ends and the gas is released, the abdomen returns to its normal size, but the stretched tissue doesn't snap back instantly. Many patients report weeks or months of vague discomfort or heaviness afterward, even though the medical chart shows no official complication. Then there's the matter of the incision sites themselves. Any cut into tissue heals by forming scar tissue, without exception. Beneath the visible skin scar, deeper scarring can form in muscle and the lining of the abdominal cavity. That scar tissue is stiff and can pull organs together into adhesions, bands of tissue that shouldn't be there, since organs are meant to slide freely against each other. Adhesions after laparoscopy aren't rare. They're a routine outcome, not a fluke. The frustrating part is how often these operations reveal nothing new, findings that were already visible on an ultrasound, or changes that don't require treatment at all. The patient goes through anesthesia, gas inflation, and an unnatural body position, only to be told everything looks fine. Then weeks later, abdominal pain shows up, a direct result of the procedure itself, not the original problem. The reasonable stance here is that diagnostic laparoscopy should be a last resort, used only once every non-invasive option. High-resolution ultrasound, MRI with contrast, Connecticut scans, and detailed blood work has been fully tried and failed to answer the question, or when the situation is a true emergency. Modern imaging and lab technology are powerful tools, and using them well is the real skill of a good physician. Cutting into the abdomen just to look around isn't a diagnostic breakthrough. It's often a sign that easier options weren't exhausted first. An umbilical hernia happens when part of the intestine or the fatty tissue around it pushes through a weak spot in the abdominal wall near the belly button. That weakness usually traces back to connective tissue, the same structural material that forms ligaments, tendons, and blood vessel walls throughout the body. When connective tissue is naturally weaker than average, it can show up as varicose veins in one person, loose joints in another, and a hernia in someone else. Different symptoms, same underlying cause. In babies, umbilical hernias are extremely common. Roughly 1 in 5 newborns has one. After the umbilical cord is cut, the opening it passed through is supposed to close on its own as the child grows. By the time most kids reach 5 to 7 years old, the vast majority of these hernias have closed without any medical intervention at all, simply because the tissue matures and the muscles strengthen. Despite this, surgery is often offered anyway, sometimes to toddlers as young as 2 or 3. The logic isn't crazy. A stitched opening definitely won't reopen. But the better question is whether stitching was ever necessary if the body was going to fix it on its own. Every operation carries the burden of anesthesia, physical stress on a developing child, and a permanent scar. There are cases where surgery genuinely is the right call, a very large hernia opening, or the risk of incarceration, where a loop of intestine gets trapped and loses its blood supply. That's a true emergency, since trapped tissue can die and require far riskier surgery to remove and repair. But those situations are the minority. Most umbilical hernias, especially in children, neither trap tissue nor fail to heal on their own. If surgery is proposed for you or your child, there's no need to rush into it. Ask pointed questions. What's the actual risk of incarceration? How large is the opening? Is watching and waiting a reasonable choice? If the answers feel vague, get a second and even a third opinion. Consistent agreement across specialists is meaningful. Disagreement means you likely have time to consider your options. There's also something you can do yourself. Strengthening the deep transverse abdominal muscle, the layer that wraps around the torso like a natural corset and helps regulate internal pressure, can make a real difference. The exercise is simple. Draw your navel firmly toward your spine, hold the tension, then deepen it further in stages until you feel real fatigue. Then release slowly. Done daily, many people notice tightening within weeks. Some women dealing with abdominal muscle separation after pregnancy have seen the gap narrow with consistent practice, sometimes without surgery. Addressing the downward shift of internal organs that adds pressure to weak spots can also help prevent a hernia from growing in the first place. It might seem strange to call a simple shot an operation, but by strict medical definition, it is one. Any procedure that breaks the skin and enters underlying tissue counts as a minor surgical act, complete with sterility requirements and its own risks. Here's what actually happens. The needle passes through skin and fat into muscle, physically cutting and displacing tissue along the way. The medication is then injected under pressure, forcing muscle fibers apart and creating a small cavity, anywhere from 1 to 5 milliliters, depending on the dose. When the needle is withdrawn, the body repairs the damage the only way it can, by forming scar tissue. One injection creates one small scar. A course of many injections over time can leave muscle noticeably denser and less pliable than healthy tissue. This isn't theoretical. In clinical settings, oncology wards, for instance, patients on long courses of repeated injections can develop gluteal muscle so firm that inserting a needle takes real physical effort. Oil-based medications, including fat-soluble vitamins and certain hormone treatments, are worse offenders because they're absorbed slowly and sustain inflammation in the muscle for longer, leading to denser scarring than water-based solutions. Complications range from mild tenderness and hard lumps under the skin to a firm, non-resorbing mass of inflamed tissue to a genuine abscess, a pocket of pus requiring surgical drainage and weeks of difficulty sitting or walking. Infections can occur even with careful technique, especially in people with diabetes, weakened immunity, or pre-existing scarring in the area. There's also a less discussed risk. The sciatic nerve runs through the gluteal region and controls movement and sensation in the entire leg. A misplaced needle can cause sharp pain, numbness, or even lasting nerve damage, which is exactly why injections are given in a specific upper-outer area of the muscle. Getting that placement right takes real skill, and not every practitioner has equal experience, which is why patient experiences with injections can vary so widely. The practical takeaway: if a medication comes in pill or capsule form, oral administration is usually just as effective. Modern oral formulations have bioavailability comparable to injections for most vitamins and many antibiotics. There's little reason to accumulate scar tissue and muscle for a benefit achievable without a needle. Injections make the most sense when there's truly no alternative. Emergencies, impaired digestive function, or medications that simply don't exist in oral form. A facelift tightens the skin and underlying muscles of the face through incisions near the hairline and behind the ears, aiming to smooth wrinkles and redefine the jawline. It's an appealing idea on paper, but the risks involved are different from those in most other cosmetic procedures. Start with the incisions themselves. Every cut disrupts blood flow along its edges, and scar tissue doesn't carry blood as efficiently as healthy skin. Over time, skin fed by vessels running through a scarred area can receive less oxygen and fewer nutrients, meaning a procedure meant to fight aging can, paradoxically, accelerate it in the long run, just not immediately. Facial muscles are also structurally unusual. Unlike muscles elsewhere in the body that attach to bone, facial muscles attach directly to skin, which is what allows expressions like smiling or frowning. These muscles connect through connective tissue to muscles in the jaw, neck, and even shoulders. You can feel this connection yourself. Tense your whole face tightly and notice tension spreading into your neck and shoulders. Then relax completely with a soft smile and feel your whole body ease. When a surgeon repositions facial muscles, That shift ripples through the connected chain, subtly altering neck tension and posture in ways that are hard to measure but real. Then there's asymmetry. No face is perfectly symmetrical, and the muscles on each side sit at different degrees of tension and length. A technically flawless, geometrically even surgical result can clash with this natural asymmetry, producing an unnatural look. One eyebrow higher than the other, or a mouth pulling slightly to one side. This isn't a rare outcome. It happens often enough to be considered a real risk of the procedure. Perhaps most importantly, faces age gradually and proportionally on their own. Wrinkles form where skin has worked hardest, around the eyes and mouth, and often read as natural because they are. Surgical intervention can disrupt that harmony. One area may look decades younger while the rest doesn't match, and that mismatch tends to be visible precisely because it breaks a natural pattern. Non-surgical alternatives focus on circulation. Your body's own blood flow is arguably the most powerful tool for skin vitality, delivering oxygen and nutrients to tissue. Poor posture, muscular tension in the neck, inactivity, and chronic stress all restrict that flow. Facial exercises can help. Gently pressing both palms over the forehead, cheeks, and chin with light upward pressure, not pulling for several minutes, can stimulate lymphatic drainage and improve circulation. Many people notice one side of the face feels different from the other during this exercise, a reflection of natural asymmetry. And working both sides evenly over time can genuinely improve tissue tone without surgery. When there's a real medical reason, cesarean section is a remarkable, life-saving operation. Situations like placenta previa, a persistent breach or transverse position that makes vaginal birth genuinely dangerous, or acute fetal distress are cases where a C-section can prevent tragedy. Nobody disputes that. The concern is different. Cesareans performed without a clear medical indication. Because a mother wants to avoid labor, choose a birth date, is afraid, or because a doctor defaults to it as a precaution rather than a necessity. For the mother, a cesarean is a major abdominal surgery. It requires opening the abdominal wall and the uterus, along with general or spinal anesthesia. The uterus carries a permanent scar afterward, which introduces real risks in future pregnancies, including placenta accreta, where the placenta grows into the scar tissue, and uterine rupture along the scar during a later labor, a genuine emergency. Recovery is also harder. The incision is painful for weeks, and everyday movements like standing, rolling over in bed, or lifting the baby become difficult. Getting back on your feet after a cesarean typically takes much longer than after vaginal birth, and breastfeeding can be harder to establish since the hormonal signals that trigger milk production are normally set off by labor itself. For the baby, there's a less commonly discussed factor. Passing through the birth canal exposes a newborn to the mother's own bacteria, seeding the infant's gut microbiome, an early foundation for the immune system. Babies delivered by cesarean don't get this same exposure and instead pick up whatever microbes are present in the operating room. Research has linked this difference to somewhat higher rates of allergic conditions, eczema, asthma, and digestive issues in early childhood. The physical compression of vaginal birth also helps clear fluid from a newborn's lungs, preparing them for that first breath, something that doesn't happen the same way during a cesarean, which is part of why cesarean-born infants sometimes need more respiratory support right after delivery. Childbirth is an area where the margin for error affects two people at once, so any decision deserves real seriousness. If you or someone you know is planning a birth, finding an experienced obstetrician who's comfortable managing vaginal delivery matters. If a cesarean is proposed without an obvious emergency, it's reasonable to ask directly what specific medical indication makes it necessary, and to seek another opinion if the answer isn't clear. A closing note on all five. Every risk discussed here, scarring, adhesions, slower healing, increases with age, particularly after 40. That makes the case for caution even stronger as people get older. Get a second opinion, ask what happens if you wait, and explore conservative options like physical therapy, exercise, and lifestyle changes before assuming surgery is the only path. The oldest principle in medicine still applies. First, do no harm.